Dr. Sharat Chandra, a former editor of Indian Heart Journal, and I was President of Cardiological Society of India in the year 2018. My job today is to bring to you the highlights of the last day of just concluded American College of Cardiology meeting. So let me bring to you some data from important trials, and the first one is the spiral hypertension on-med trial. As you all know, there has been a lot of enthusiasm and interest in renal denervation therapy over the last several years. Few years back, you got this Simplicity 3 trial, which has actually put a lot of water in the imagination of the interventional cardiologists, and it was a negative trial. And after that, despite the results of Simplicity trial, the enthusiasm of the researchers has not gone down, and later this particular device has come, which is a radio frequency denervating therapy for the renal arteries. And let us see the data of the long-term efficacy and safety of renal denervation on blood pressure in patients on antihypertension medications. This was presented by Dr. Felix Mahfoud, who is a regular participant in most of these trials, and he's one of the brains behind these spiral trials. All right. So hypertension continues to be the leading cause of death worldwide, and poor adherence to antihypertensive medications is frequently observed. Catheter-based renal denervation has been demonstrated to safely lower blood pressure in sham-controlled trials out to 6 months, and in real-world patients up to 3 years. The data that is going to be shown now is the 3-year data on this particular trial. Okay, see, the objective is to look at the data at the end of 36 months. Okay, the device that was used here is a spiral catheter, the Simplicity catheter, which is a multi-electrode non-occlusive catheter design. It gives radio frequency energy with a power control algorithm. It is compatible with a 6 French renal guide catheter, and one device can be used for all the vessels ranging in the diameter from 3 to 8 millimeters. Treatment not only of the main vessel, but the branches and accessory renal arteries also can be carried out with this. All right, what is the algorithm of this? What they have done is, the trial was carried out in 25 sites and multiple countries. It is a proof of concept trial. The inclusion criteria were office systolic blood pressure more than 150 but up to 180, and diastolic blood pressure more than 90. 24-hour systolic blood pressure was can be anywhere between 140 to 170. The patients are relatively stable on 1, 2, or 3 antihypertensive drugs for 6 weeks. The drugs could be thiazide diuretics, ACE inhibitor, ARB, beta blockers, or calcium channel blockers. One is the patients are randomized to 2 arms. One is the renal denervation arm along with medications. The other is the sham control with medications. The patients are followed up at 3 months, 6 months, 12 months, 24, and 36 months. Okay, and if required, some patients can be crossed over. Okay, so the number of patients who are randomized in this were 80 patients, approximately 40 patients in each group, and they are followed up, as I said, at multiple intervals. The baseline characters are more or less similar between the two groups, between the renal denervation therapy group and the sham control. The age is around 53, and males were about 87%, about 80% of the patients. The only matter of concern in this baseline characters is that there were significantly more number of patients in the sham control suffering from obstructive sleep apnea. 2 patients in the RDN group versus 10 patients in the sham control group. That's a matter of concern, because we know that obstructive sleep apnea is one of the important causes of resistant hypertension and is not easy to control. So that point has to be accepted. All right. Now, what are the baseline characters in relation to blood pressure? The systolic blood pressure was 164 versus 163, diastolic blood pressure 99 versus 102, and 24-hour systolic blood pressure was 150 and diastolic blood pressure 97, which is more or less very similar between the two groups. Antihypertensive medications, number of medications was more or less similar between the two groups, but if you look at the complete medicine burden, the number of medicines and class and dose, it was slightly more in the sham group, and the lesser number of medication, less medication burden in the RDN group. Look at the change in the 24-hour SBP over course of time. You can see clearly that the RDN group had greater fall of systolic blood pressure from the time of beginning to the end of 36 months. There was a certain fall in the sham group also, but that was significantly less. Now, if you look at 24-hour systolic blood pressure, morning systolic blood pressure, daytime systolic blood pressure, nighttime office SBP, in all of them, the RDN patients fared better than the sham group. That's an important point. The 24-hour BP at baseline in 36 months, if you see, there is a significant fall in the systolic blood pressure in the RDN group. There was a slight fall in the sham group also, but that was significantly less. So the same thing holds good for the diastolic blood pressure. So the patients with the 24-hour SBP less than 140 millimeters, they are significantly more often seen in the RDN group than the sham control group. 83% achieved systolic blood pressure less than 140 compared to the sham group, which achieved it only in about 44% of the patients. Safety events at 36 months were not significantly different. There were hardly any safety issues in relation to this therapy. The conclusions of this spiral hypertension on medicine trial is the radiofrequency RDN group compared to sham control demonstrated clinically meaningful BP reductions independent of concomitant antihypertensive medications up to 36 months without safety issues. So there were no safety issues, and at 36 months, there was significant blood pressure reduction in the RDN group. Given the long-term safety and efficacy, RDN provides an adjunctive treatment modality in the management of hypertension. These long-term results are specific to radiofrequency catheter-based RDN procedures, and it may or may not be generalizable to other RDN modalities. So that is about this particular trial. This was simultaneously published in Lancet, as you can see here. Now let me take you to the next trial. The second trial I'm going to talk to you about is a trial that looked at a very important current problem, that is the incidental or clinically meaningful detection of thrombosis beyond the leaflets in patients who are undergoing TAVR. We know for some time that this matter is going around, and people are very concerned about the development of thrombus behind the leaflets in patients who have undergone TAVR. So a lot of brainstorming has been done. One really doesn't know what is the final word in this. This is one more important trial that has told us something about the role of anticoagulation. All these days, the matter was discussed whether anticoagulation should be given to patients who undergo TAVR to take care of this particular problem. Now, this is a trial that was presented by Dr. Park from the Asan Medical Center, which you know is one of the very important interventional cardiology centers in Seoul, or for that matter in the world. This trial tested edoxaban, one of the NOACs available, versus dual antiplatelet therapy for leaflet thrombosis and cerebral thromboembolism after TAVR. And this trial is called the ADOPT TAVR randomized clinical trial. The study design is that there were about 220 patients who did not have any indication whatsoever for oral anticoagulation following successful TAVR. They were randomized, about half of them to administration of NOAC without any antiplatelets, and the other half to aspirin plus clopidogrel. There were about 110 patients in each group, and the clinical endpoints are that looking at leaflet thrombosis on 4-dimensional echocardiography or cardiac CT at 6 months after TAVR. The key secondary endpoints were, of course, the serial brain MRI and neurologic and neurocognitive function tests at baseline and 6 months, because that's what is really important. If thrombosis is developing, then is it leading to clinically meaningful events, or is it just a asymptomatic thing? Let's look at the data. All right. Baseline characters of these population, the intention to treat population is more or less they are similar. The age is around 80 years in both the groups. Men formed about 40% of the total population. Body weight less than 60 kilos was in about 50% of the patients. These were high-risk patients, demonstrating a significantly increased STS risk score and Euro risk score. And about 90% of these patients underwent balloon expandable valve implantation versus about 10% who underwent self-expanding valve implantation. All right. Both the groups, the patients achieved very encouraging reduction of the trans-aortic valve gradient, with a mean gradient at the end of the TAVR of about 13 to 14 millimeters in both the groups. And the ejection fraction post TAVR was about 64%, which is also a very encouraging result. Okay, so 4-dimensional CT primary endpoints to look at in whether it is related to intention to treat group or the PP population. The valve leaflet thrombosis was reduced in patients who were on edoxaban compared to those patients who went on dual antiplatelet therapy. But this was not statistically significant. And the MRI endpoints in these patients, whether it is presence of new cerebral lesions or median number of total lesions or median volume of total new lesions, there is not much difference between the two groups. And neurological and neurocognitive endpoints, you can see here that again the outcomes are more or less similar between the two groups, that is those who used edoxaban versus those who used DAPT. The conclusion is that the overall incidence of leaflet thrombosis on CT scans was less frequent with the edoxaban therapy than with the DAPT therapy, but it did not reach statistical significance. The incidence of new cerebral thromboembolism on brain MRI and new development of neurological or neurocognitive dysfunction were not different between the two groups. There was no association between subclinical leaflet thrombosis and temporally related changes of new cerebral thromboembolic lesions and neurologic endpoints. So what do we conclude from this? That it appears from this data that it goes with the general thinking that this thrombosis is probably an incidental thing. It does not require long-term anticoagulation. It probably needs just a single antiplatelet therapy. In fact, the consensus all over the world is that if you just give them one single antiplatelet therapy, that is enough. There are many centers which use dual antiplatelet therapy for 6 months, because most of the cases we use bioprosthetic valves in this TAVR equipment, and therefore it is expected that by about 6 months the endothelial ligation is over on these leaflets. So now let me take you to the third presentation. I'll talk to you about the PROTECT trial, which is a trial that looked at the hypothesis that warming patients aggressively in non-cardiac surgery also is important, and that will reduce to improve outcomes of the patients. So in this, what they have done is aggressive intraoperative warming versus routine thermal management during non-cardiac surgery. This is published from the Cleveland Clinic. This is a work done from Cleveland Clinic. And the hypothesis is this is tested at 30 days outcomes. Primary thing is aggressive warming to a core temperature of nearly 37 degrees. It prevents a composite of myocardial injury, cardiac arrest, and death. The secondary hypothesis is aggressive warming to 37 degrees reduces deep or organ space surgical site infections, decreases red cell transfusions, shortens hospitalization, and decreases the need for readmissions post-discharge. So this is a randomized thermal management trial. What does routine thermal management versus aggressive warming? In the patients who went for routine thermal management, the target was 35.5 degrees. And there was no pre-warming before the surgery or fluid warming. That is, warm saline was not infused for these patients. All that the patient gets is, if the temperature is less than 35.5 degrees centigrade, the patient is given a benefit of forced air cover, and it is this is activated only if the core temperature is less than 35.5. In the aggressive warming arm, the target is to get 37 degrees centigrade as early as possible. And there is a 30-minute pre-warming with forced air before the patient is taken up for surgery. And during surgery, patient is infused warmed intravenous fluids, and 2 intraoperative forced air warming covers are given. Now, this is the aggressive warming versus the routine thermal management. And the target which has been made has been achieved perfectly. You can see here at the end of 5 hours, the aggressive warming group very quickly actually reached 37 degrees. On the other hand, the routine care group reached the temperature which was targeted, that is 35.5 at the end of 5 years. In fact, much earlier than that, at the end of about 2.5 hours or so. So the aims what have been actually planned have been achieved in this. And let us look at the outcomes. Now, if you look at this, you can see here that the myocardial injury is not much different between the two groups. Non-fatal cardiac arrest was more often seen in the control group, but again here it is not statistically significant. And the various other parameters like the mortality, there is no difference. Surgical site infection, transfusion requirement, hospital readmissions, they were not different between the two groups. Randomization to 37 degrees versus 35.5 degrees core temperature does not reduce cardiovascular composite, individually only powered for myocardial injury, does not reduce surgical site infections, transfusion requirement, or duration of hospitalization or readmissions. However, intraoperative temperatures of more than 35.5 appears to be safe. So this is the concluding trial which I am showing you. The ACC.22, as it has always been, has been very encouraging, and a number of new trials have been published. Let me conclude today's talk by saying that we'll all hopefully meet once again during and after ACC 23. Good day to all of you. Thank you very much.